Well, good afternoon. My name is Mike Mack, and I'm a cardiac surgeon from Dallas, Texas, and we're here at the Society of Thoracic Surgery meeting in Los Angeles, California. We're fortunate to have a very distinguished panel with us today who's going to discuss the role of transcatheter aortic valve replacement and the role specifically of surgeons in this. We have as I mentioned, a very distinguished panel, and I'd like each of them to introduce themselves, starting with Dr. Zito over here on my right. Wilson.
Well, thank you, Mike, for arranging and organizing this. It certainly is a privilege to be here. My name's Wilson Zito. I am a cardiovascular surgeon from the University of Pennsylvania, from Philadelphia, and I've been involved with TAVR, and it has certainly been a privilege to be doing so.
Neil?
My name's Neil Kleiman. I'm the lone interventional cardiologist at the session. I'm from Methodist DeBakey Heart and Vascular Institute in Houston.
And you notice, Neil, that we put you in between all the surgeons, so.
But you're on tape.
Vino.
I'm Vino Thorani. I'm one of the cardiac surgeons at Emory University in Atlanta, Georgia. And again, thank you very much for allowing me to participate in this very important endeavor.
So, all of us are involved with heart teams as we deliver TAVR procedures to patients. Wilson, perhaps you could start by telling us how it works at the University of Pennsylvania. Who's on the heart team, and what is each person's role on that heart team?
That's a very good question, and our heart team is a multidisciplinary approach at the University of Pennsylvania, similar to most programs. Not only are the cardiologists and surgeons fully engaged, with equal partnership in evaluating patients, not only doing so, but also participating in the operating room with a hybrid OR, but as an extensive team that includes neurologists, anesthesiologists, perfusionists, and the mid-level nurse practitioners and research coordinators that help us try to manage such a big endeavor and operation in managing these patients. So it is a big team that fully is in the spirit of collaboration.
So Neil, about 5 or 6 or 7 years ago, when all of us knew TAVR was coming, there was a lot of angst in the surgical community about how surgeons gain wire skills and experience in TAVR. Can you kind of march us through how things have worked at Methodist in Houston and what the role of the surgeons are, and have you been able to successfully train any of us?
Well, the short answer is absolutely yes. We've been able to train the surgeons very nicely. I feel very comfortable with my surgical folks doing the catheter-based skills. It took a few months to get everyone comfortable. Part of that's not only having the surgeon being comfortable with the technique, but probably a little tougher is to have the cardiologist comfortable watching the surgeon use a catheter. But those skills are fairly basic. They're not difficult to learn. We've also learned that the degree of caution that the cardiologist will apply when entering a vessel, for example, it's a little different than the way the surgeon will view it, simply because conversion to an open repair isn't a big deal for the surgeon, whereas to a cardiologist, it's something very daunting.
So Vino, you're an extremely experienced TAVR surgeon. You train traditionally in cardiac surgery. How did you get to become so experienced? Where did you learn your skills?
Well, I gained a lot of the experience in preparation for knowing that we were going to have transcatheter valve program at our institution. So in 2007, as we knew we were about to enroll in the partner trial, I spent about 6 months to 8 months actually in the cath lab. And I had 1 day a week where I was dedicated to being in the cath lab, and Vasilis Bavoulouros and Peter Block actually taught me how to do catheter-based skills. And that's really where I gained my uptick in structural heart catheter skills. And from there, I've continued to work with a cardiologist in gaining that. I think that potentially the new people going into transcatheter valve may need an extended 6 months to a year fellowship, and we're offering that. But there are different ways of doing it. At the beginning, that's how I started. It's just being in the cath lab and working with cardiologists and learning from them.
Wilson, you've got a very busy program at the University of Pennsylvania. How many surgeons and how many cardiologists perform TAVR procedures, and how do you bring new folks on? Do you have a fellowship program? How are you teaching younger surgeons and cardiologists TAVR skills?
I think that's a great question and is an important question. Our initial team comprised of 2 surgeons and 2 cardiologists. But as you alluded to, the volume of TAVR has significantly increased over the last 4.5 years. Currently, we have 5 surgeons on the transcatheter team who are actual implanters, and there are now 4 cardiologists who are also part of the team. Now, training, you bring up a good point, because one of our academic mission, is education. And we have a robust training program, not only in the core residents, the ABTS residents, where they have early exposure not only in the cath lab, but with the TAVR procedures, but certainly residents who have finished their accredited training and now are seeking additional fellowships. And we offer 1-year fellowships for those fellows who want additional training in catheter-based therapy.
So, Neil, there's a number of practicing both cardiologists and cardiac surgeons out there who have no experience, have no access to a large center. How do they gain the skills, or how do they begin to participate or get a TAVR program going in their hospital?
Well, the first thing they have to do is there's a fair amount to learn about TAVR before you even get close to starting. So we spent about a year learning some of the basics well in advance of doing our first implant. I think that's the basic skill. The second skill is that all of those individuals need, A, to be comfortable working with one another, and B, to be comfortable taking care of critically ill, very delicate patients with advanced valvular heart disease. I think once those things have happened, then there are a number of centers that are developing as training centers where these procedures will be taught. The other thing is that there are now a number of people in the U.S. who are very good at doing this procedure and who are very good at teaching it. And, for example, in our own institution, after having been fairly busy for the last 2 years, we are still very excited when we can get someone who's more experienced than we are to come down and help us with some cases.
So, Vino, we hear a lot about the heart team. Is it real? Is it just lip service? And if it's real, is it going to be able to stay together long term?
Very good question. I do think it's real. I do think still to this day, after, and I know this for a lot of the large volume centers, cardiologists, surgeons are making decisions together on the type of patient we're going to operate on. They're meeting together about the type of access that's going to be utilized to do this procedure. So I do think the heart team is, in 2013, January, it is still alive. As the profile of the devices and the new generation devices come about with smaller and smaller devices, and the 60-40 split of TF-TA maybe becomes 80 or 90% TF, and only 10 to 20% become non-TF platforms, I'm not sure that the heart team is going to stay together. It will sadden, I think, a lot of us who started doing this in 2006 and 2007 in the United States. I hope it stays together. I think part of it depends on CMS reimbursement. If CMS reimbursement stays in place where surgeons and cardiologists are required for reimbursement, I think it will. My fear is, my hope is that it will not, for basically logistics reasons and also for reimbursement reasons, that we won't be able to keep it together. But it's the future will tell.
Wilson, how does the heart team work at the University of Pennsylvania? Do you just do procedures together? Do you evaluate patients together in clinic? Do you take care of them, patients post-operatively together?
That's a very good question. And to echo what Vino just mentioned, I find a cardiology, surgery, heart team relationship very sacred. I think there was some skepticism early on, but that, at least in our institution, that relationship has even gotten stronger over the last 4.5 years. It's not just a procedure that we do. together, pre-operative evaluation, post-operative management, and just as important, long-term follow-up. We do it together in the valve clinic. So I think it's a commitment at your institution to keep the heart team concept going, if that is your commitment. But I agree with Vino Thorani that there may be non-medical pressures that may threaten to compromise the heart team concept.
Neil, you've got a newfound friendship with Dr. Reardon at Methodist Hospital. Can you kind of speak a little bit about the dynamics of how you two function together on the heart team?
We really run the heart team very closely together. Virtually everything that we do is done jointly. We have 2 joint valve clinics per week that are staffed by Dr. Reardon's team and by our team. We review studies together daily. We see patients together almost daily. And then we perform the procedures together, as well as manage the administrative details jointly together almost on a daily basis. So the partnership really is exceptionally close. And I've got to say, it's nothing like I'd ever imagined, even as we started.
So we've got about 2 minutes left here, Wilson. So everybody likes to hear about what's going to happen in the future. Can you give us your 30 seconds of what the future of TAVR is in the United States?
Great question. I think TAVR will continue to increase in terms of its penetration in the market. I hope we can do it in a responsible way. But I think certainly with technological advancement, we've seen it in all fields, that there will be continued improvement and refinements. So my parting shot, I believe, is that TAVR will continue to improve so that we can better serve our patients, but it will be just one of the platforms that we can offer patients with valvular disease.
Vino, your insight into the future?
I think that, as Wilson mentioned, there will be refinement of the procedure, but I think that what we will see hopefully in the next 1 to 2 to 3 years is refinements in the complications that occur with the current first-generation valves. So we'll see hopefully devices to decrease paravalvular leak rate, to decrease stroke rate, and vascular complication rates. So I think we're going to start seeing hopefully that progression over the next couple of years to mitigate some of the morbidity and mortality we're worried about earlier on in Generation 1 devices. So hopefully that's really what we're going to see in the future.
So Neil, we would like to thank you for coming to join us here at the Society of Thoracic Surgeons. And to show that we're good hosts, we're going to give you the final word on the future of TAVR.
Well, I think there are several things. I think we will see refinement of the devices and of the technique. I think we'll see refinement of the post-operative management. We'll learn more about anticoagulation and antithrombotic strategies in these patients. I think on the front end, we'll learn more about the diagnostic procedures we use to select patients for TAVR. We've learned the hard way that not all patients with aortic stenosis are appropriate candidates for the technique, for the procedure. So I think we'll see all those things advance. And I'd be a little remiss in my job if I didn't remind people that we'll see 3-year partner results at the ACC in March.
Great. Well, I would like to thank the panel for a great discussion. We hope that our audience finds this to be of value as they embrace this new technology and this new pathway of being able to treat patients with severe aortic stenosis. Thank you very much.